So thank you very much, Dr. Shumit Chaudhary, for giving me this opportunity of being a part of your prestigious instruction course. So I'll take everybody through neovascular glaucoma, co-ablative procedures, which and when. Cyclocoablative procedures, which and when. So that's neovascular glaucoma. On your left is rubeosis that you can see at the slit lamp, and on your right is the blood that you can see in the angle, rubeosis in the angle on gonioscopy. So treatment of the underlying process is very important. Pan-retinal photocoagulation at the slit lamp, endolaser, retinal coablation, transscleral retinal ablation, and diode transscleral cyclocoablation. So treatment of the raised intraocular pressure is done generally medically, that is aqueous suppressants, beta blockers, carbonic anhydrase inhibitors, alpha agonists, avoid pilocarpine and prostaglandin analogs. Topical atropine 1% is required, and topical steroids. So treatment of raised intraocular pressure could be surgical. It could be a trabeculectomy with antimetabolites or aqueous shunt devices or cyclodestruction. My topic today actually concentrates on cyclodestruction. So we have the cyclocryotherapy and you have the TSCPC, other contact and non-contact transscleral cyclodestructive procedures, or the endoscopic cytophotocoagulation. So high rate of failure in all the methods. Cyclodestruction is actually associated with incidence of hypotony, phthisis, postoperative pain, intraocular hemorrhage, and loss of best-corrected visual acuity. Adjuvant treatments are anti-VEGF, all the anti-VEGFs that are available, and the intravitreal triamcinolone provide a window for definitive treatment and make surgery easier, not sufficient alone for management of this condition. So if we move on to this, cyclophotocoagulation is divided into transscleral cytophotocoagulation and endocytophotocoagulation. So cytophotocoagulation reduces the aqueous production by destruction of the ciliary epithelium. The techniques are transscleral, transpupillary, and endolaser. Indications are failure of multiple filtering surgeries, primary procedure to elevate pain in neovascular glaucoma with poor visual potential, painful blind eye, surgery not appropriate. So diode laser transscleral cytophotocoagulation method of ciliary ablation with success rates of 40 to 80% performed with the 810 nm diode laser, 1500 to 2500 watt for 1.5 to 3 seconds, and a total of 18 to 24 spots. Endoscopic laser photocoagulation performed with, again, the same diode laser, and xenon light source provides illumination, and the helium neon laser aiming beam, starting settings at 0.25 watt with continuous exposure time. The actual time of exposure is based on visual effect of the ciliary processes shrinking, and you can see the whitening. Typically, as much of the ciliary process is treated as possible, as there is a significant portion posteriorly that is actually not treated. So cycloplegics are not necessary, and steroids are used in the usual post-operative dosing. So laser treatment, cyclodestructive procedures, we have the continuous wave cyclophotocoagulation, that's the ab externo and the ab interno, and we have the micropulse cytophotocoagulation. So ab externo cytophotocoagulation, destruction of the ciliary body to reduce aqueous humor secretion, as I told you, and lower intraocular pressure. Anesthesia is needed as the procedure is painful. And laser treatment with endocytophotocoagulation, that's the ECP, that's how it's done, that you can see those ciliary processes getting white as you proceed with the procedure. And ab interno cytophotocoagulation, that's endocytophotocoagulation for mild to moderate glaucoma, done with cataract surgery, relatively low risk glaucoma treatment, and it's not done in uveitis. So the endocytophotocoagulation is a cyclodestructive procedure, and it functions to minimize the disadvantages of more traditional cyclodestructive procedures, delivers laser energy to the ciliary body, ablating the ciliary body epithelium to decrease aqueous formation and thereby lower the intraocular pressure. So the micropulse cytophotocoagulation, that is what has popularized in the recent days, and it's a gentler form of cytophotocoagulation, appears to work very much like the drop pilocarpine. It has a mechanical effect, no restrictions on one's activities, and it's a low risk profile. That is how it is done. You actually go from in a semicircle on the hemispheres, and that is actually Cytophotocoagulation uses a low application of laser energy that is chopped into micropulses, and there's a gap between each micropulse that you give. It does not burn or destroy the eye tissue, and that's 33% of IOP reduction at 18 months has been achieved in this study, and 61% were off medication or reduced medication. So at a glance, micropulse transscleral cytophotocoagulation has proven to be safe, effective, and reliable approach for lowering intraocular pressure. Unlike other interventions, it delivers energy in a 31.3% duty cycle, allowing tissue to cool between each application. So there is minimal impact on target tissue and a reduced risk of injury to adjacent tissue, ocular tissue. And it can be used early in the disease course and requires minimal medication, reducing the reliance on anti-inflammatory drops and post-procedure. It can also be used on a wide range of glaucoma severity cases, those who are most advanced cases of the disease progression. Next, we move on to ultrasound cycloplasty. It's a novel device employing high intensity focused ultrasound for the coagulation of ciliary body with the aim of achieving selective coagulation of the ciliary body while sparing the adjacent structures. The high intensity focused ultrasound is a non-invasive procedure that delivers highly concentrated sound waves to the ciliary body, reducing aqueous humor production and increasing the outflow, thereby lowering intraocular pressure. So UCP brings about a reduction in intraocular pressure via multiple mechanisms of action that result in decrease in aqueous humor production by selective destruction of the ciliary body, increase in aqueous humor evacuation, and by inducing the stimulation of the suprachoroidal and transscleral portions of the uvascular path flow. So this is the procedure that I did, and so that's the machine that is used, and I'm just starting all three videos at the same time so that you can have a look. Yeah, and that's the semicircular cup coupling fluid is put in that normal saline, and that's the instrument. You have to actually, there's a docking procedure, and this green line that you see is that the instrument is docked into the eye, and then you apply the ultrasound waves, and it's a problem in the video here. So once you've done it on one hemisphere, you turn it as I'm turning it, and then you can do it on the other hemisphere. And this is where you can actually see that the ultrasound wave has been applied on these quadrants. You can actually choose, and there is a gap of 20 seconds between each application. So that is where, this is where the ultrasound waves are being applied. And once that's the calibration. And once this is done, that those red spikes that you see as the ones where the ultrasound wave has been applied, and then this is over, it becomes red, and then there is again a gap of 20 seconds, and then it will again go on to the next quadrant. So we did a study on this and results of the therapeutic ultrasound for refractory glaucoma over 1 year. So 38 eyes were treated with a mean follow-up of 18 months, and the mean follow-up in intraocular pressure was 38.6%. Analysis of the three success criteria was success varied between 74 to 78% at the mean follow-up time. Complications occurred, mainly inflammation, conjunctival congestion, and pain in 8.4%, including thysis bulbi in 0.4% and persistent hypotony in 1.1%. There was no mean loss of visual acuity. So it's quite a satisfactory procedure, but of course needs to be popularized, and we need more studies to come up to actually be sure that we can do it in eyes which are not with so much severe glaucoma. Therapeutic ultrasound appears to be safe and effective for the treatment of refractory glaucoma. So the difference with TSPC and the high index, what I showed you ultrasound, is that it's the energy is concentrated over a smaller area than over a larger area. So it is actually preferable to the transscleral photocoagulation. So comparison of the two, I found Yu et al. Both UCP and TSCP are safe and effective methods for the treatment of refractory glaucoma. Nevertheless, pain is less severe in UCP. And Graber et al. Said that the success rate of significantly higher for cyclodiode treatment as compared to the HIFU cyclodestruction when treating refractory glaucoma. However, significantly fewer complications were observed with the high-frequency ultrasound photocoagulation as compared to the cyclodiode. So based on cumulative evidence on the safety and efficacy of these techniques, the range of indications for cyclodestructive procedures may be expanding so that patients with less severe disease and overall better prognosis are treated with such modalities. The role of cyclodestruction in glaucoma management will most likely continue to evolve because of the introduction of novel technologies such as the endoscopic diode cytophotocoagulation and circular high-frequency cytophotocoagulation and micropulse transscleral diode cytophotocoagulation. Early evidence with these recent introduced technologies suggests they have a clinically acceptable efficacy and favorable safety profile. Confirmation of these promising data with larger studies with adequate follow-up is needed for these modalities are more widely adopted before they are more widely adopted in clinical practice.